get started in just about a minute to let more people sign on. Okay, hello and welcome to our webinar, Ask the Expert, Rare Uterine Cancers. I'm Kitty Silverman, the Uterine Cancer Program Director at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. We're a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with breast or gynecologic cancers and provides outreach to the general public about signs and symptoms. For more information about upcoming webinars, support groups, and our helplines, please visit our website at sharecancersupport.org. I just want to share some information about today's format and a few housekeeping reminders. Dr. Lee presented a webinar on rare uterine cancers back in July, and there were so many questions that Dr. Lee kindly offered to come back and do this program, which will be strictly devoted to answering your questions about rare uterine cancers. In addition to the pre-submitted questions that we received, you can ask questions today using the Q&A feature at the bottom of your screen. Please remember that presenters are unable to give specific medical advice, so please keep your questions general in nature. In order to answer questions from as many people as possible, we will try to limit questions to one per person. We will try to get through as many questions as we can, but may not be able to get to all of them due to time constraints. All participants will be muted during the presentation. We also have closed captioning available. You can enable this feature by clicking the live transcript button on the bottom of the screen and selecting the subtitle option. The webinar is being recorded, and the recording will be shared with all registrants and will also be added to our website. Now I'd like to hand things over to Dr. Nita Lee to introduce herself.
Hi there. Thanks everyone for joining today. My name's Nita Lee. I'm a GYN oncologist at the University of Chicago. So I do surgery and chemotherapy and drug delivery, as well as a focus on survivorship. I also help to direct our fellowship, and I serve as our Cancer Center's Associate Director for Community Engagement and Outreach. And so particularly, I'm always really happy when we have the ability to share what we're kind of hearing about from like newer studies, or kind of like helping to kind of like bridge a little bit of a gap that sometimes happens between what we're thinking about clinically and what patients are hearing and learning about. So I appreciate the opportunity from SHARE to talk about this topic, which is really important as the disease of uterine cancer has gotten even more attention, which is good, but it's also made it a little bit more confusing too, in terms of some of the vocabulary that we use in thinking about it and a lot of the classification. So I'm excited to get going. I really hope that I can answer all of your questions, but I also do recognize that many of you are experts in your own disease, and you are going to know a lot of things, and I'm going to do my very best to answer all the questions.
Thank you so much, Dr. Lee. We did have a few questions, so we thought a good place to start would be to talk more about the new FIGO staging guidelines, which came out, I think, within the last few months, right?
Yeah, I think this is really an important place to start. I think the whole community of GYN oncologists across the world is like just now starting to kind of wrap our heads around it and how do we utilize it. And so FIGO, which is the Federation for International sort of GYN Oncology, changed some of the guidelines to include some of the newer information that we know affects how patients may do, and how the original staging, which is sort of like, where is the cancer located? What are the risks related to that cancer? We know that with uterine cancer, a lot of it really does vary by kind of the histology or the cell type. Obviously, there were a lot of questions about high risk cell types such as carcinosarcoma or uterine serous carcinoma. But we also know that the genetics and some of the molecular testing that we do now for uterine cancer also may impact the sort of the outcomes of like how we can predict best how people can do. So the newer staging system system tries to take that into consideration. So for example, some of the higher grade or more potentially aggressive cell or histological types, which is the other terminology for what the cancers look like under the microscope, are kind of upstaged because we know that they may behave a little bit more aggressively. And I think the important part about that is, I hope you don't hear this background, like crazy stuff in my office. I suddenly have some construction happening outside my window, which I didn't anticipate. So I think that the issue is that sometimes the stage changes, but truthfully, we had actually been treating patients based on what those cell types were differently, right? So not all stage 1A were treated the same. It really depended on your cell type. So for example, serous carcinomas or carcinosarcomas were actually given additional chemotherapy and radiation when they're only stage 1. Right. And now this new staging takes into consideration some of those things. It's a little more details about like where maybe like tumor involvement in lymph nodes. And it also has a designation to be able to do some of the molecular testing and then kind of report that back out. And that's important because some of that molecular testing and classification may help us like do less treatment in patients whose molecular profile suggests that they could have a better outcome even without treatment, or may help us to decide about adding treatment after their initial surgery. So that's kind of a very broad overview, but I think it's important to think about that the new staging system takes into consideration not just the location of where the cancer cells are located, but it takes into location the disease cell type, as well as the molecular type. And so those are some of the newer terminologies.
That's great. Thank you so much. That's such a good, thorough answer. So we have a number of questions about uterine carcinosarcoma. And maybe you could start with just a little information about that subtype, and then we can talk a few of the specific questions.
Yeah, no, that would be great. So uterine carcinosarcoma is a subtype of endometrial carcinoma or endometrial cancer in general. For many years previously, not so much recently in the last 5 to 10 years, but for many years, this was almost treated as like a separate entity. So it was considered to be like, oh, it's separate than endometrial cancer, it's its own thing. So that really limited patients who had a diagnosis of carcinosarcoma from being on the same trials, from being, and yet it's a very rare tumor type within uterine endometrial cancer. But it is known that this is actually a variant of endometrial cancer that has these characteristics of cells that look both like a carcinoma, which means they look like a gland, and sarcoma, which look like sort of some of the supportive tissue that is in the uterus, but they all sort of derive from similar places. And so the reason that it's important is that it is considered one of our higher risk uterine cancers. And so those are things that we know have a higher risk of coming back and a higher risk of us actually wanting to do treatment ahead of time to try to prevent as much as possible. So I think now many studies that are done really try to group carcinosarcoma with endometrial cancer, but they may report out how do carcinosarcomas in particular do, because I think we're really interested in making sure we're targeting that group because it has always behaved a little bit differently.
Thank you. Here's a couple of specific questions about, this is an important one. Is there any progress on treatments for a recurrence of carcinosarcoma?
Yeah, there really is. It kind of, goes twofold. There have been a lot of series of trials that were looking at like the standard, what we call cytotoxic or the standard chemotherapies. Those are chemotherapies that many people have heard of before, where those are chemotherapies that are designed to kind of like kill off rapidly dividing cells. And those cells basically are treated. And so historically, there were some different chemotherapies that were specifically targeted for carcinosarcoma. carcinoma. Those included the carboplatin Taxol that we now use as standard, but included older drugs such as ifosfamide or ifosfamide and Taxol. So there's a whole series of older drugs that sometimes get used. But there's also really importantly some newer data on even immunotherapy with carcinosarcoma. So one of the newer trials that came out last year was the Ruby trial, and they had about 10% of their patients who had endometrial cancer. It was maybe 6 to 10, depending on which categorization, were carcinosarcoma. So they included them in the larger cohort, and that was the one using carboplatin Taxol and dostarlimab, which is another immunotherapy. Immunotherapy, just as to back up, is a way of targeting your body's own immune system to try to help rev it up. And one of the things that we think about is trying to get around the signals that tumors make to help evade your own immune system. So tumors sometimes secrete materials and have proteins on the outside of their cells that help them hide from your immune system. And some of these newer drugs, the pembrolizumab, the immunotherapy, but at the thing is the case. And I see Barbara is in here, said, I'm upset that you're giving an intro on carcinosarcoma. And Barbara, I'm not trying to make anybody upset, but I do think we try to kind of make sure we know what the newer drugs are for everyone. I agree. But I think the issue is that when we think about targeted agents for carcinosarcoma, we really have to think about like what are the molecular testing and like what is the immune environment that carcinosarcoma may have that differs. So I agree that that's a really important area for us to be thinking about. And so when you look at like a series of drugs that are sort of available, we really think about how does the molecular profile really drive what treatments are. So some of the other treatment options that have come up, none of them are actually FDA approved for carcinosarcoma specifically. So I think that's important. I've been trying to kind of talk a little bit about some of the ones that are. When we think about some of these other trials, a lot of them are actually using combinations of immunotherapy and PARP inhibitors, which we don't really see that much in uterine cancer before. So I agree that like a lot of what we're looking at for carcinosarcoma is really based on like what we're learning about the molecular profile of it, which again, a lot of it depends on like which tumors have some of these targets or not, and then utilizing those drugs to be able to like better define who goes on to the trial. And so while their immunotherapy is not completely new, it's not standardized yet. And so I think we really want to push for that.
Thank you very much. I think you kind of answered this question in the last one, but what options are available if uterine carcinosarcoma is unresponsive to chemotherapy?
So I think it depends on like which chemotherapy regimens have been like used already. Sometimes it actually means that you may need to have somebody who's, we talk through like repeating the biopsy to see how the cells may have changed either by their molecular targets or even by their morphology. So sometimes usually when patients have recurrence, their cells are actually going to be carcinoma when you see the metastasis in other places. Sometimes we'll actually see carcinosarcoma, the metastasis be actually sarcoma. And so then we sometimes will actually use some of the sarcoma regimens like the ifosfamide that I mentioned before, or adriamycin, which is another like older drug. So the other thing that happens is that we often look at some of the sarcoma sort of features to see if any of the drugs that we use that are targeted for specific proteins that sarcomas can make, those are some of the other ways that we look at it. So a lot of it then becomes like super specific about like how we can, what we can do to individualize the care.
Great, thank you. I'm going to go over to serous carcinoma. We may come back to carcinosarcoma depending on time, but I want to make sure we cover as much as possible. So maybe, Dr. Lee, we could do a little like we did with the carcinosarcoma,
Sure.
and talk a little bit about serous carcinoma, and then I'll get into some more specific questions.
Yeah. So uterine serous carcinoma is also one of the rare subtypes. It has like the morphology looks like ovarian cancer. So sometimes people have treated it that way, but I do think it has very specific other potential benefits in terms of like what other drugs we use. So this is also another cancer that even in early stage, we often treat with chemotherapy. And this is also a very important like cell type where we actually look at like different other molecular testing. So one of the testing that we use, for example, is HER2 testing, which people may have heard of for breast cancer. We also look at the P53 signature, which is kind of how people get diagnosed with serous cancer sometimes, which is one of the other molecular ways to target it. This is also a drug that, I mean, this is also a cancer that because it has a higher risk of metastasis, a lot of the studies that are looking at recurrent endometrial cancer have a high percentage of patients with serous histology in it. And so some of the ways that people are looking at triaging what to do best is going to be based on, again, like what is that molecular profile? Like, is it HER2 positive? Is it, like, so, does it have some of these other molecular features that would make it more potentially beneficial to do immunotherapy for? So I think that it's hard because not everyone's cancer is going to fit into a profile of a completely targeted agent, but I think we're trying more and more to get those, get that vocabulary into our patients so they know to ask for that, right? Like, what was my HER2 testing? What was my molecular testing? That way your doctor can individually go over what are the specifics of your cancer as far as we know, so we can kind of go through this list of drugs that we have that could be beneficial.
That's great. Thank you. Are there any maintenance drugs to reduce the chance of recurrence of serous cancer? This person was NED after completion of
Yeah, so I think the ones that are used most often right now, and this has changed a little bit with for patients who have a more advanced serous cancer, meaning that it was located outside of the uterus, there is data to suggest that use of Herceptin or trastuzumab, which is a monoclonal antibody against the HER2 protein, could be beneficial in those patients. And I think the ongoing studies are, should we be doing that even earlier in the disease process, meaning like even in patients with stage 1 or stage 2. Right now, we generally get that approved for patients who may have more advanced disease. It's treated completely surgically. Maybe it goes away with chemotherapy, but that is often another maintenance option for patients. Now, there are some newer drugs that are sort of like kind of like sister drugs of the Herceptin that may have activity for lower levels of the HER2 protein. And that's actually also been something that's exciting to think about in terms of like maybe they would be able to have some benefit in the serous carcinomas as well.
Okay, great. Thank you. This question is a little more specific. Asking about some new advances in treatment of recurrent uterine serous cancer and survivorship for postmenopausal Black women. And I don't know if that's a question.
Well, I mean, I think that like, I don't think that there are specific, like, they're not treatments that are like, necessarily that we really think about dividing up by race or ethnicity, but I do
Sure.
think it's really important to just recognize that, among women, all women who get serous carcinoma, Black women are more likely to get a high risk cell type like that. And so I do think that that means that we need to be very aware of doing the same thing in terms of like making sure we understand the molecular profile and making sure that we're thinking about that in terms of like appropriate follow-up, making sure people are linked in to care. Survivorship as a whole, I think, is really important in terms of thinking about sort of like these like bigger pictures that everyone does mention and think about, which is just like, how are you doing in terms of like your overall mental health? How are you doing in terms of like, what are your needs in terms of diet and nutrition and physical activity? We do know those things can make a difference. And they can also prepare you in case you have a cancer that is going to potentially come back and you may need to be back on treatment. I think people being more, more fit with that do better, right? And so I think it's a little bit, I don't think I have something that's very specific. There is a fantastic study that is through one of our organizations that I think you guys have also worked with as well, which is ECANA, Dr. Dole, who's given lectures here as well, the Endometrial Cancer Action Network for African-American patients. And so ECANA also has some wonderful resources for African-American women who are dealing with a uterine cancer diagnosis.
Yeah, they're a wonderful organization. Thank you. Is it true that serous or UPSC are not estrogen driven?
So traditionally, most of the time, they're not as estrogen driven. There's still some data to suggest that there are probably some serous that are mixed, meaning like you can have a mixed cell where the predominant is serous, but you may have some endometrioid as well. So sometimes you can get some like very focal estrogen receptor positive tumors in the entire tumor. But in general, we don't see the serous cancers as really predominantly estrogen driven, meaning like we don't generally utilize anti-estrogen therapy to treat them because most often the tumor cells are estrogen receptor negative.
Okay, thank you. And actually this question just came in. Does clear cell uterine cancer return more often than others?
You know, I would say that probably the rates of return in early stage cancer are probably a little bit higher in serous and carcinosarcoma. That being said, it can vary because there's some data to suggest that the clear cell cancers may not be as responsive to chemotherapy, but that doesn't always hold off to be true. And they are considered in all of the different chemotherapy trials.
Okay, thank you. Yeah, well, it's actually, since that question was just asked about clear cell, if you could tell us a little bit more about clear cell, and I have a couple of other questions.
Yeah, I mean, clear cell carcinomas of the endometrium are, again, another rare cell type, and where there has been sort of mixed pictures and mixed decision making about like, should we be thinking about like really aggressive chemotherapy up front? Should we be thinking about, you know, radiation? So many people will often think about radiation as well as kind of like other factors when we're thinking about clear cell cancer in particular. And the hard thing about those is that because within any type of study, unfortunately, there's still sort of like a lesser like percentage. It's sometimes people feel like they have a harder time deciding whether like a pure clear cell cancer is going to do the same. And so I think, you know, we know that having those clear cell features may predispose somebody to have a tumor that may be more likely to go deeper, or may be more likely to go to outside of the abdomen. And so I think that's where clear cell kind of comes in as a high grade, as a high grade type, but there's less really defined on like whether or not we should like treat them differently. For right now, most are actually treated very similarly. The carcinosarcomas, the uterine in the early stages, that is uterine cancer, uterine serous, clear cell, and carcinosarcoma are often very much treated similarly.
Okay, that's good to know. Thank you. And somebody was asking, do you ever see clear cell uterine cancer that does not reoccur? I guess because the recurrence.
Yes, I mean, we definitely have times where we don't see that happening. So we, you know, and there, but I think that's the same. We also have times when we actually think about you know, like serous cancers that we still, you know, there's a lot more that we don't know, that we do have patients who get treated with their original chemotherapy, or some in patients with radiation where we don't recur. Clear cell cancers, I think one of the things that is important though, is that we sometimes have like another set of drugs, like along with the immunotherapy we talked about, is that there's this other set of drugs that are called tyrosine kinase inhibitors, which are just like another profile. When I think of targeted agents, I think of like, what are all these things that get turned on when you have a cancer diagnosis, and what are the different targets? And so clear cell carcinoma sometimes gets studied with renal cell clear cell carcinoma, which can actually look very much like that. So the kidney cancer can look like the uterine cancer. So there are some drugs that have been like developed in that space that sometimes we look at for clear cell cancer.
Okay, thank you. We have a lot of questions coming in live, so I'm going to go down to some of those, and then we'll come back to some of the resubmitted ones. I'm sorry, the previously submitted ones.
Yeah.
Well, this is a very general one, and I know there
Yeah.
has been a lot, but let's go for it. What research is being done on uterine cancer since 2022? And I know there've been a lot of breakthroughs recently. So
Yeah, I mean, I think that, just even this weekend in preparation for this, I was looking online and, like looking at like at one of at the European meeting, there was some newer data that was looking at the addition of the immunotherapy with PARP inhibitors. And so I think that's going to be a really exciting new area. I think the standard for now for patients who have advanced endometrial cancer really across the board is going to be chemotherapy plus immunotherapy, versus if patients have had chemo before and are newly recurrent, it may be immunotherapy based or based on the data over the last 3 or 4 years, which was the Lenvima pembrolizumab. I know that's older data. I think the issue though is that like a lot of these trials, I think people are really interested in, again, how specific can we be as to like who's going to benefit the most, right? So a lot of the trials also have kind of these like molecular like targets at the same time that they're studying, so that when we pick a trial, we're actually picking it based off of like somebody's like profile, and we're not just putting like all groups into the same. And so a lot of the trials will report out. One of the things that people look at for endometrial cancer, which is really important, is this idea of like the MMR testing, or so the mismatch repair genes, like are they deficient? Are they proficient? So you'll often see things called DMMR, which means that there is a deficiency in the mismatch repair genes, which is a way that cells repair their DNA. So that categorization of deficient versus proficient often kind of helps dictate like which chemotherapies or immunotherapy you would use. And so a lot of the drugs, we know that like majority of patients will be proficient in MMR and won't be immunotherapy won't be as good for them, right? So we're really targeting that other group to say like, what can we add to immunotherapy to really drive up the response rates? And so I feel like that's kind of what I think is really important for people to really understand, like, what is the molecular profile of my tumor and how do I kind of like figure out which of these things could be, most helpful.
that makes a lot of sense. Somebody asked, when might radiation rather than chemo be suggested for recurrence that was in a single lymph node?
Yeah, I mean, I think this is always like, we never say never. We always have to fine tune a very specific like treatment. So it's not, radiation has a lot of effect and can be very successful at controlling things locally in small areas, right? So sometimes we would use radiation, for example, if somebody was like not eligible for chemo or something like that. Sometimes if it's somebody who's responding to certain chemo, but there's one lymph node that's not responding, right? So there's some data to suggest that might be a time to use it. Or if a recurrence happens in a single lymph node and that person has been on a lot of treatment and I feel like they really need a chemo holiday from the amount of chemotherapy or immunotherapy or targeted therapy they are, I might choose to use radiation in that one area to be able to extend the time from when they have to have some harder treatments. So a lot of it depends on the location, as well as like what other treatments they would have had before.
Thank you. Somebody's asking about mRNA, liquid biopsies, and CART.
All really excellent questions. So I really do. I think that the issue with the circulating tumor DNA, so is this idea of like, can we use other molecular testing in the blood, like a blood test, because one of the things with uterine cancer is that we've never really had a great blood test, right? So many women who have serous carcinoma will sometimes have a CA-125 test, but it's not as accurate as it is for ovarian cancer. And so this is, a newer area of research in both colorectal and lung cancer and uterine cancer and ovarian cancer to say like, can we find these tumors earlier before they're actually finding something on the CT scan? And so those trials are actually ongoing. We don't have like an actual like FDA approved test right now that's going to be like perfect for endometrial cancer, but people are particularly interested for that for like all of the high grade cancers.
Thank you. This question comes up a lot in our support groups, and this, could be related to any type of uterine cancer at all, is about scans. And after following treatment completion, at what point should the patient have a scan, and what are the pros and cons of
Yeah,
scanning?
I think that's a really good question. I really think this has to be like a question that you feel comfortable with as a patient with your provider. So in patients who have early stage disease, maybe they had a stage 1 or stage 2, and we feel that like whatever their initial treatment was, that they did not have any other disease that we could see. I usually have a conversation to say like, well, how often are we going to actually do a scan? Like what would be beneficial in patients who have more advanced stage disease, such as patients who had disease in their nodes or in the peritoneal cavity. I think I tend to lean towards more scans because I think their risk is higher, right? In some patients, we'll kind of talk through people like, so it also may differ by age. I have some patients who are in their 80s and say, look, you know what? I feel really good. I don't want to have another scan unless I have a symptom, right? And that has traditionally been how people felt about uterine cancer in general, even in the high grade stages, or sorry, the high grades. I feel like for my patients who are interested in like doing surveillance, I talk them through the idea of like, well, would we want to do sort of maybe like an initial scan at 6 months and then maybe at a year? And then as time goes by, do we stretch that out? The downsides to scans are the fact that they do have effects on potentially on your kidney function. If you happen to have somebody whose kidneys are not working as well, you can also find a lot of like incidental findings, and you have to kind of follow those going forward. So it can lead to a lot of like anxiety around like, what is that if we don't know for sure? But I don't think it's like what as cut and dry. Some of the older studies suggest that we didn't change how people did long term by scanning and driving people crazy by doing a lot of scans, but that what mattered was their exam and any symptoms that they had. But I think the way I think of it is that like I have a conversation with the patient about like, hey, these are what I think your risks are. Like, how do we want to go forward? What do you feel comfortable with? Like, would you feel comfortable with saying 6 months, or do we feel, and a lot of it depends on like, where was their disease to begin with? So my higher risk patients, I tend to scan a little bit more.
That makes a lot of sense. Are there any, or if there are, what types of uterine cancer may be connected or result from endometriosis?
So endometriosis in general has a little bit more of a relationship to ovarian cancers than it does to endometrial cancers, and the terminology can be very confusing.
Right.
So I often think of endometriosis in relation to endometrioid types of ovarian cancer and clear cell carcinomas of the ovary, but not as much of the endometrial lining itself. Now, I'm not saying that people with endometriosis can't have that, but that's usually not like, because endometriosis is generally like a sort of like a benign pathology that happens on the outside of the uterus.
Okay, thank you. This is a very good question, actually. What would you recommend as the best place for patients to find information on the most current research?
That's a really tricky one. I do think that like we try to put as many things, but if you're interested in kind of like looking at like some of the papers, I mean, I think SGO will often has practice statements. If you can look at like some of the things like OncLive usually does interviews with different people who've like newly published some abstracts. And then kind of being aware that there are different meetings that where newer data is presented. So SGO is one of them. ASCO in June is another one. The ESMO meeting, which is the European meeting. There's an international meeting that happens as well. This year it's in Korea later. So these big meetings, a lot of researchers wait until those meetings to be able to present their data and like on a larger scale. So if people are really interested in kind of honing in on saying like, hey, I want even more details about this, I would say think about those meetings. Many of those meetings actually have like either online or in person, like free things for advocates and things like that. So I would try to see if that's something that interests you, or sometimes even getting involved with your own cancer center's research side. So we're always really looking for patients who may be interested in saying, hey, look, like, I want to take a deeper dive in this. And I think in those circumstances, we've had some patients who've been like part of our research advocacy teams and working with some of the basic scientists or some of the translational scientists who are looking at like the next targets. And that's how they feel like they stay involved as well.
Thank you. This is an interesting question. Is there benefit to having more chemo radiation past what is considered the national standard?
No, I mean, I think in general, older studies had been done on like, hey, is 8 better than 6? And should we just keep it going? In general, we tend, if it's after surgery, we tend to do sort of like a combination of 6 chemotherapies once every 3 weeks. And then there's some other different like maintenance options. There's not a lot of great data to say that like 6 is greater than, is better. I mean, 6 is like 8 or 10 is better. That being said, if somebody has a cancer and we're dealing with a recurrence and we're seeing things shrink and it's continuing to shrink and someone is tolerating the chemotherapy, there are times where we continue the chemotherapy beyond a certain like set point, but we always have to balance like the side effect profiles.
Sure. And actually that segues into this question about side effects. What kind of anti-sickness tablets are effective in controlling nausea? And also another question from that same person, do steroids help stop nausea during during immunotherapy? Sorry.
So for sort of standard chemotherapies, there are definitely drugs that are given the day of the chemotherapy and given afterwards to kind of see like what are, like to avoid that. So those include drugs such as like Zofran or Reglan or, a lot of the other drugs that are sort of like utilized as part of the IV package as well. And then I think, steroids can be given as well, both for preventing allergic reaction, but in patients who've had kind of like bad nausea or vomiting after their chemo, then they can actually also get their we can use an extended course of steroids to help that. Immunotherapy in general, most patients don't have a lot of nausea, but some people can have this like GI side effects, and you can use steroids, but it's a little bit less, like more that you're targeting the effects of the immunotherapy on your gut as opposed to kind of like just like in general, like it's not as like reliable in terms of like the kind of the time and the onset of like when people feel the worst after regular chemotherapy. Sometimes with immunotherapy, it can be a little bit different.
Okay, thank you. Can you speak about the state of research and treatments for, I hope I'm going to get this right, for uterine carcinosarcoma, MMMT?
Yes, so MMMT is actually just uterine carcinosarcoma. It's actually the same terminology. It was an older terminology that was referred to as mixed Mullerian tumors, malignant mixed Mullerian tumors. And so some of the terminology that you'll see in pathology reports, not so much anymore, but sometimes people will have been told, hey, I have an MMMT tumor. But what that just means is that it is a carcinosarcoma.
Oh, okay. Okay, thank you so much. I wasn't sure what, okay, so let's see. We have, well, this one, I think somebody asked it about serous carcinoma, but this could really apply to any, if there were any, and if you can answer this, if there are any dietary changes that you would recommend.
I think we don't, nothing's perfect, right? So if there was, so I do think the question that we get asked most often is like, hey, should I cut out all sugar from my diet? And will that make a difference? And so I don't think it's that you have to cut out like all sugar per se, but I think like a balanced diet of like less processed foods is probably like in general what we would recommend. Obviously, there is some good data on like just physical activity, improving outcomes and improving tolerance of chemotherapy. So increasing that, whether that means like getting a physical therapy consult to have them help you come up with like a home regimen, or just staying active through walking or yoga, some things that are kind of like more easy to get into. I think those are the things that we think of. There's not one set, but I do think like maintaining your protein intake, less processed foods, less added sugars are kind of overall what I would think of.
Sure, that makes sense. Somebody wrote that they thought that their carcinosarcoma developed from vaginal estrogen cream, which I'm not.
I mean, I think that there's not it's hard to know. I mean, like unopposed estrogen by mouth has been associated with increased risk of uterine cancer. Vaginal estrogen alone has not been in larger studies, but then again, there have not been a lot of large studies on vaginal estrogen. So I do think that vaginal estrogen is really important as for patients after menopause to help with like sexual function, urinary function, those kinds of things. So I don't know for sure. In terms of that, like it's very hard to tell. Not all carcinosarcomas are estrogen receptor positive either, so it's harder to find that link per se. But I know everybody's individual case, it's hard not to kind of think about those things.
Sure, sure. Now, this is a very tough question, but and pretty general, but let me go for it. With a rare cancer and different opinions on treatment options, how do you make a decision on whose recommendations to follow?
Yeah. This is a very good question. Well, I think there's a couple of things. There are some things that are standardized, and sometimes you can think about like, there are patient, for example, the NCCN guidelines are actually like a national body of different people in GYN oncology who help go through the data and the evidence and put forth the data, right? There are patient, you can read, these are all free and available. You just need to have an email to register. It's completely free. You can read the patient versions, you can read the provider versions to kind of see what are some of the standards. But even then, you'll see that like sometimes there'll be like 3 things that are listed as like, these are just as good. So then I think talking to your doctor about like, okay, like what is the data on, what is my cancer? What are the places that you can think of that I would, like, why would you choose one or the other, right? Sometimes we're choosing one or the other based on side effect profiles or prior treatments or potentially like future, like kind of thinking about like staggering treatments. And so you're right, you may get different opinions, but their opinions should not be that different than what is sort of like on the NCCN guidelines.
Okay, great. Thank you.
Sometimes you'll get some different opinions about whether to layer in radiation and chemotherapy and immunotherapy. And that a little bit is a constant debate between many of us who treat uterine cancer, is that some of the newer data does favor chemotherapy and then the addition of radiation, the addition of immunotherapy. But there is some good older data, especially among patients whose maybe disease was really all along the lymph nodes and not elsewhere, where radiation may actually be very helpful too. Now, radiation in any of these studies really hasn't shown to be, it's more effective in that local area, but it doesn't affect potentially the risk of the cancer showing up elsewhere. And that's why we tend to do the other treatments.
Oh, okay. Thank you. This is a really good question. Can a CT or MRI scan detect 100% how far the tumor has spread, or is it only through surgery that everything?
Yeah, it's not perfect, so
Yeah.
CT is really good at like looking at lymph node enlargement. So if a lymph node is enlarged beyond like 0.5 centimeters or 1 centimeters, then the CT scan will often say, hey, this looks like it's kind of, pathologically, like it's bigger than it should be. We should target at this at surgery. But it's not perfect in terms of the sensitivity of like what is that percentage of like, it's, if your scan is completely negative, there's a pretty good chance, but we still feel like there's probably a small percentage, maybe even up to like 5 to 10%, that patients we still will check the lymph nodes to make sure microscopically there isn't something else, right? And so in general, that's what's like tough about these scans, right? So they're the best that we have, so we can best plan for surgery and radiation, but we do know that they're limited because under the microscope, if something is not enlarged, we might see it under the microscope, but not under the scan.
Okay, thank you. This is actually 2 questions which I'm going to kind of put together. What can, if anything, be done before, during, or after chemo to prevent or treat chemo-induced neuropathy? We'll start with that.
So chemotherapy, neuropathy, and I think there's another question about like orthopedists who specialize in joints, bone, pain, mobility. I think that's, so I think physical therapy can definitely help for both of those things. For neuropathy, there have been a couple of studies that have looked at the use of like immersion in colder like water or ice during the time of the Taxol, or the paclitaxel is usually the drug that's going to cause the neuropathy. Some of those have been mixed in the breast cancer literature. People have used them. There's some, I remember seeing an abstract last year that was looking at the idea of not just cold, but compression for both hands and feet during treatment as potential. We also know that there are other drugs. The drug that's probably the most like ASCO's recommendation prediction based off of like looking at a lot of different studies is a drug called Cymbalta, which some people shy away from because it is in a class of drugs that's related to drugs that are used for depression as well, but at a lower dose, they can be helpful for neuropathy. So I think physical activity, physical therapy, potentially movement, and these compression or cold treatments are some things that people have looked at for peripheral neuropathy. And then in orthopedists, I don't know if there's as many orthopedists, but there are sometimes like these rehab physicians, like physical medicine and rehab, or physical therapists who really do cancer care rehab. And that can be either during chemotherapy or after. And more data is coming out that like fatigue related to chemotherapy, sleeping better related when you're on chemo can definitely be helped by physical therapy. So I think in terms of like joints and pain and mobility, those are some of the things that I tell people.
Okay, great. Thank you. Going back to a clear cell question, where does clear cell tend to recur when
So
it does?
it can vary, just like any uterine cancer. It can go along the lymph node spread, or it can go into other organs. So sometimes we'll see patients who recur, and they recur in the lymph nodes along in the abdomen or even in the chest area. We have also in any of these organs can also occur in like spots in the lung or the liver. It's not, all of those are considered to be like spread outside of the original place where it started, so distant. And so any of those are things that you can see, or you can see just within the abdominal cavity, sort of implants that are sitting on the bowel surface.
Oh, okay, thank you. I think you may have touched on this a little, so excuse me ahead if it's a little repeated. Did you talk a little bit about PARP inhibitors and how they're starting?
I just happened to see this interesting paper that was just published, or just the abstract that was just put out, that was looking at the addition of PARP inhibitors, which is another targeted drug that got a lot of attention because of ovarian cancer, and really a lot of effect in patients with BRCA1 mutation carriers, one or two. So BRCA mutation or any other type of these like molecular changes or genetic changes that were BRCA-like. So PARP inhibitors by themselves in uterine serous cancer or carcinoma has not been a lot of like activity that people have looked at that. But I think people are now looking at it in terms of, in addition to immunotherapy, as well as if somebody happens to be our BRCA mutation carrier and have a uterine cancer, then that they may be, it may be beneficial to think about that too.
Oh, okay, great. Here's a question. I'm not sure that is it possible, or how rare is it to have multiple types of endometrial cancer at once?
So it's not necessarily multiple types, but it can be. So many of the patients who have serous carcinoma or clear cell carcinoma or even carcinosarcoma have kind of a mixed tumor. So within the lining of the uterus, some of the cells will look like endometrioid and maybe a different grade, and some will be high grade serous. Usually they're all high grade, but once in a while you'll have somebody who has a very low grade cancer and then a high grade cancer serous. And so I think that there can be a mixed cell type, and that's how it's referred to, depending on the percentage of what the pathologists see.
Oh, okay. Okay, that's very interesting. Thank you. Somebody just wanted to get the spelling of the immunotherapy drug that you mentioned.
Oh, one of the drugs that was, one of the drugs, I'll put it into the chat. That might be the easiest thing, or I can't figure out. I'm going to say it wrong.
Oh, I don't think we have the chat.
Oh, okay. Then I can send that to you. But yeah, so that drug that was considered, it's part of one of the trials that's called the Ruby trial. So that trial was actually looking to see if adding the chemotherapy and the immunotherapy would be helpful. And that's where that drug came from. And so that is called dostarlimab, MAB. That was one of the studies that was published in the New England Journal of Medicine. There were two studies that were published at the same time. Both of used the backbone of carboplatin and Taxol and then added different immunotherapy regimens. The dostarlimab study actually allowed for carcinosarcoma to be in them, and that's often referred to as the RUBY study. And then the other study did not allow carcinosarcoma, but had all of the other types. And so some people have said, well, does that mean that we should be using carcinosarcoma? Like, we should be preferentially be using that drug instead of pembrolizumab? So there's I think we use all of the drugs, but that study did happen to use one of them.
Okay, great. Let me see what else we have. We have about 5 or 6 more minutes. Let's see. Now, this is actually an interesting question because it's come up for us a lot. Does the medical community consider uterine and endometrial cancer the same? And
yeah,
I
would say that yes. I mean, so when you think about like all uterine cancers, there are other uterine cancers that develop from the muscle layer. And so those are generally uterine sarcomas, not carcinosarcoma, but uterine sarcomas. And so, I mean, of all uterine cancers, like 90% are endometrial, so it gets lumped together. And when you look at the national statistics and you're looking at like how, what are the rates of, uterine cancer in the country, it includes all uterine cancers, sarcomas, and all these other rarer types, but it's really driven by the endometrial cancers because they make up the majority of it. I think there had been a question somewhere in the chat about adenosarcoma, for example. So that is another cell type that actually doesn't arise in the lining of the uterus, but may arise a little bit differently in the in some of the supportive tissue or the muscle layer. And so those drugs, those types of rare uterine cancers may have their own profile, and that we don't always use immunotherapy. They're often hormonally positive, so sometimes we use hormone. There are some times where we use radiation a little bit more in those cancers too. So it varies a lot.
Oh, okay. Thank you. Here's one: PET scans versus CT scans versus MRIs.
Excellent question. So sometimes when we're planning for surgeries, I think that like we sometimes will think about MRIs because it can better tell us like how is the tumor going into the cervix? Like what is the tissue on the side of the uterus looks like? CTs and PETs in general are pretty similar in some ways. CT scans are better at measurements because you can get an exact measurement of a lymph node, or, many insurance companies won't always cover a PET, so we have to be careful with that. If there's a CT that's done and there's a question about like, hey, is that really an active area of cancer or not? Sometimes a PET CT is layered on. And then after that, then I'll use the PET to say like, hey, like, did the PET show less and less activity? Because I think that may help me more decide if it's working or not. Some people like routinely get PETs at the very beginning of their treatment trajectory just to see like what else is out there because it's head to toe. But I think CT and PET tends to be fairly, people kind of get it. It's a little bit up to the provider and a little bit up to the question at hand, right? Like if I'm really looking at measurements and I really want to add up measurements, for example, anybody who's on a clinical trial, you have to get the CT scan because the measurements are much more accurate. The PET scan is kind of like shows you the hot spots and may give you a trend of like something getting better, if that makes sense.
Okay, great. Thank you. I think there were 1 or 2 questions like this, which were just, general post-treatment advice. I know you touched a little bit on the diet, but for people who've gone through one of these rare uterine cancer diagnoses, any other things they can...
I mean, I think it's more just like, it's a fine balance between kind of being like too hyper aware, so we're driving you crazy, right? We're like, great, you're done, everything's good, now tell us if something goes wrong, right? And then so you're left with this like sense of anxiety of like, if there's a new symptom that recurs or what should you do? So I think being being aware of the need for surveillance, going to your regular checkups, and then really kind of just thinking about it in terms of like, if there are new symptoms, pain, bleeding, anything else like that, like how can you, advocate for yourself to kind of go and see your doctor to see if there's a scan that may be recommended or something else like that. It's very hard because it's like impossible to kind of say like, oh, you should focus on stress reduction. You should focus on this. I think it's trying to think about like, what are your individual coping mechanisms for how to deal with a little bit of the uncertainty that that unfortunately the cancer diagnosis puts in the world, right? Like, so once you've had that diagnosis, that uncertainty is often what people struggle with, whether they're 1 year out, 5 years out, 10 years out, right? And so individualizing like how you're going to think of like your coping mechanisms for that, and how do you kind of get yourself out when you're worried and start to feel like you're spiraling down in a pathway of being more fearful. Those are kind of probably some of the things that I tell people to focus in on.
Thank you. And actually, while we're talking, I was just thinking that we hadn't touched upon genetics at all. And
Yeah.
we all know that Lynch syndrome can be linked to uterine cancer. Are there any of these rare or uterine cancer?
There was some case reports of like maybe BRCA1 being associated perhaps with serous carcinoma, but it's not as a strong of as strong of a linkage as is when you're thinking about the ovarian cancers. And so that is something that may change in the future in terms of genetic testing, especially as genetic testing is becoming more available. So most people will get some of what the MMR testing that I was mentioning, and that can help guide too, to see if like you have to go down the pathway of looking for Lynch syndrome. High-grade endometrial cancer, in particular, serous and carcinosarcoma, are generally not as associated with Lynch syndrome. Like Lynch syndrome
Okay.
tends to be the lower grade cancers.
Oh, that's interesting. I didn't know that. Okay, that's interesting. Okay, I think we're going to wrap up very soon.
I
Just
think I
seeing if
did see one question that was somebody had some different questions about like different like terminology, like endometrioid, mismatch repair, not otherwise
Oh,
specified,
okay.
like all of these things. And I think that's really important. So like what that, and again, I'm not trying to get into like one person's like specific diagnosis, but the idea is that like that whole like idea is like trying to give your physician as much information about the tumor type, right? So mismatch repair deficient may mean those are patients who immunotherapy may actually work better for by itself, right? So those are patients who, if they're facing a recurrence, may have the option of whether or not they go on chemo and immunotherapy or just immunotherapy itself based on what other factors and what other treatments they have. So all of these classifications are really about knowing like the mismatch repair or MMR state of like, are you deficient? Is it proficient? Sometimes you'll see little d MMR, little p MMR to distinguish that. And then the endometrioid refers to the cell type.
Great, thank you. Yeah, I know that those molecular cell types have really changed a lot of what's happening in uterine cancer. So
Yeah, for sure, for sure.
yeah, so that's, well, I think this is a good place to stop. And we thank you so much, Dr. Lee, for these incredibly thoughtful and thorough answers to these many questions. And we will have a recording of this program available on our website in a couple of weeks, and we'll also send you an email. And please make sure to check SHARE's website for upcoming educational programs and support groups. And don't forget to follow us on social media. And please take a minute to fill out the survey at the end of the webinar. It will pop up in the browser when the webinar ends, and the link will also be in a follow-up email. And all surveys are anonymous. So this concludes our program for today. We cannot thank you enough, Dr. Lee, for joining us. And
thank you so much for having me. I really appreciate it. I know this is really tough, and I wish we could, go into everybody's details, but I think there is a lot of hope in terms of like the amount of new things that are coming out and the targeted drugs that are, so I think just asking the right questions, asking your doctor, how do you fit into the newer drugs patterns, it will be really helpful for sure.
Absolutely.
All right. Thank you, everybody.
Thank you. Wishing everyone well and have a great.
Okay. Thank you.
Bye.